Good morning, everybody. It's me, Dr. Kevin Stevenson. Thanks for joining me on this week's episode of I Don't Care with me, Dr. Kevin Stevenson. Always appreciate you joining me. I know you've got a lot of other things that you could be doing, but thanks for spending some time with me, and hopefully I bring you some decent information through my guests. And my guest today is he's got an unusual perspective on healthcare. Dr. Krishna Vedala, is simultaneously he's a practicing internist, he's an obesity medicine specialist, he's a physician exec, he's an AI advocate, healthcare leadership commentator. So, Kristen, welcome to I Don't Care.
Thank you so much for having me.
Hey, it's great to have you. Anything else you'd like to share about yourself with my audience?
Well, not much. I'm a Sooner fan.
Oh,
I know.
no.
I'm sorry. I'm sorry. Maybe I shouldn't have started off with that, but
No, that's all
gotta be
right. That's
honest.
okay.
I have 3 degrees from.
You bailed out on us. You bailed out on my Baylor Bears, left the Big 12
I
for
know.
what you thought were greener pastures in the SEC. But
I wouldn't really call it greener pastures. I kind of feel I'm still nervous about the whole move because I don't want Oklahoma to be the Minnesota of the 2000s. That's my number one concern. For all you football fans, yes, Minnesota was a powerhouse in the 50s, but before the 50s, and now it's really not there. So I do have that fear, but I have 3 degrees from OU, so I kind of have to be a Sooner fan. Otherwise, it would really create a life existential crisis. But really just a Sooner fan, Oklahoma City Thunder fan. I have one kid with my lovely wife, who I always say is my biggest accomplishment of my life, is my wife. And we have another one coming here in a couple of weeks. But that's pretty much it about me. Just I'm just your regular, simple, a little bit nerdy, a little bit sportsy guy. That's all.
hey, we've got that in common. Then that's great. So with your broad perspective and looking at healthcare through all those lenses,
Mhm.
what do you see as the biggest problem that we're still pretending that doesn't exist?
I think there's a significant segment of the population that believes this system is working, but it's really not, right? It's really not. People always tell me, well, it's not really broken. Why fix it? Well, it's broken. Oh, it is. It's just we don't want to accept that fact. And the reason I say that is about 50% of Americans actually at times have to make significant financial decisions when it comes to their medications, their own healthcare. And I've had patients where I need them on a certain, dosing of insulin. Well, that's a little bit expensive. Can we do this? Or I need them to go take this test. Well, I'm a little bit worried. Well, I'm worried about you having a blood clot. Why don't we get this ultrasound? Well, can I go to the ER? No, you don't want to go to the ER because it's more expensive. It adds more overall to the healthcare system. I can get the ultrasound. Well, I can't afford $300, right? So that's the problem. And I don't really think that I think we're at a place where we can sense it, but I think we're also at a place where a significant segment of the population does not want to accept that fact. But we're there, no matter whether if you see it or not, it's happening right in front of our eyes.
Boy, I'm glad you brought that up. I just got back from a conference yesterday, and somebody brought up something I hadn't really thought about, and he was talking about access, and he said, my family and I have really quality healthcare insurance, and so. But I contacted my primary care physician. I couldn't get in for 3 months. So even though I have good insurance, do I really have insurance if I can't get in to see somebody? So yeah, I mean, I think you're right. I think the system is broken, um, and there are a lot of people who like the broken system that we have because they're benefiting from it. But there are a lot of people who see the system as being broken and they have no idea what to do to fix it because it's been broken like this for so long. So
This is something that I've been trying to put together, which is a series of articles about the kind of correlations that we see within the healthcare industry these days in our country, but also with the private railroad industry back in the 1920s and 30s and 40s. And there's very some frightening similarities. You have back then. So for all your listeners, I'm also somewhat of a history buff, and so part of the problem that we have right now is no matter what city you go to, you see that there's only 2 or 3 hospital systems that have kind of dominated the geographic area. Here in Oklahoma City, we have Integris, Mercy, St. Anthony's. In Tulsa, you have St. Francis, Hillcrest, St. John. In Wichita, you have Wesley and Via Christi. Little Rock, you have Baptist, UAMS, and St. Vincent. And back in the 1920s, it was the same scenario with the railroad industry. You had only a few of the giants that were really cutting everybody else off, and farmers and other labor unions had to pay more. And we're seeing something similar with physicians and hospital systems. 80% of all physicians are now employed by a hospital system. And you only have the remaining 20% that are struggling. We just had a really cool obesity medicine practice here in Oklahoma City with Dr. Ryan Morgan. He had to shut down. And now he's working as a hospitalist at the local VA. And I asked him, I said, what was it? And he said, well, insurance wasn't really working with me. And he didn't want to transition to a DPC model at that time. It was too difficult. Logistic costs, overhead costs are always hard. And this is someone mindful that ran a very tight clinic. He didn't overgo in terms of the aesthetic look and all that. But I think there's a lot of scary transitions between the healthcare industry that we see today and how you had a thriving private railroad industry that literally by 1960s, 1970s, by the time President Nixon came up and decided to make a quasi-government institution now that we know today as Amtrak, I think we're probably headed in that direction. And, that's something that I've always find fascinating, but I think it's something that we're going to continue to see.
Interesting. Interesting. And we both brought up the primary care issue now. And so I think you can go one of two ways with primary care. Have we truly broken it, or did we just stop valuing primary care? What do you think as a primary care physician?
I don't think we have stopped valuing it. I think everybody knows deep down primary care is the foundation of a strong health system. If you're trying to build a hospital system, you're going to need primary care to send referrals to your specialist, and you need that. But you also need primary care to send people to your hospital, to the inpatient side, and also to manage the outpatient side so you don't keep bringing people back into the hospital. But I think the issue is I think there is some degree, and I hate using this word, some degree of greed. But I also think there's a lack of understanding of how primary care works. You can't manage primary care like you manage a specialist clinic. Nothing against specialists. Orthodox cardiologists see 30, 40, 50 plus. That's great. And they're really great at what they do, but that's because they're mostly focused on one issue, right? You have a broken knee. Okay, you have, history of stents. All right, well, we'll just get a stress test and get you set up, to a left heart cath. Either you have a broken knee, that's fine. I'll get you in a couple of weeks to boom. Primary care doesn't work that way. It's much more complex. And so when I think people come to terms with the fact that you cannot make or assume that primary care is going to be a money grinder, then I think things will work well. But when you're applying business models for a specialist clinic to a primary care clinic, that's the problem. And that's the issue. I will say this, many of my friends that have left primary care, they've always had one or two similar issues, which is I can't look at the homework that I have to take home, and I can't see the numbers that they want me to see. And where does that come from? That comes from a lack of understanding of how primary care functions and how important it is to keep primary care docs, I wouldn't even say happy, just satisfied with what they're doing. I'm not talking about paying them, money or giving them, three or four nurses. I'm just saying keep them satisfied, right? But even that's being hard to ask at this point, and that's the sad part.
Yeah. Well, I know here in my community, there's two brothers who are primary care docs who are phenomenal, and everybody in the community loves them. Anybody who can get into their practice did. And then their parent organization decided, oh, you know what, we're going to drop a direct patient care model, concierge practice model into every community that we serve, and we need some people to do that. And the organization went to these two brothers, and so, and I'm really good friends with one of them. So I was asking him after the fact, after he and his brother decided to go the concierge route with the organization. I said, how's it working out? Why did you make that decision? He said, honestly, he said I was seeing so many patients every day I couldn't chart, and I was charting until 3 in the morning, and then having to be back in the office by 7:30. and he said, I had a few options. Either I was going to leave medicine, I was going to die, or I was going to go to the concierge model. He said, I picked the lesser of the three evils. And he said, and so we said, we were talking about that. And then on the flip side, I know a number of my friends who went to them as physicians before they went to the concierge model who are angry, who they've been with these guys for 20, 30 years, but they couldn't or didn't want to pay the concierge fees. And so I think that there's definitely the interjection of greed, number one, and the desire on many organizations and many healthcare leaders to try to fix something that frankly wasn't that broken. Why don't you focus on something else that's much worse than going to two of your best physicians in the community and say, oh, you've got to go this route. So you've made a lot of people angry.
And that's something that I find just really sad, which is I know that patients want to, not just patients, anyone would want to not to spend as much money as possible on anything, right? At the end of the day, and I get that part, but I think the sad part is I don't think a number of patients really understand the intricacies that are involved in being a physician on behind the scenes, whether if that is continuing to educate ourselves, whether that is continuing to understand the new administration rules, which keeps changing here and there. And now we also incorporate technology. I'm a big advocate of AI, and I do believe that AI can be a tremendous asset to physicians if trained correctly. But I think the issue is a lot of times patients tend to take their anger out on physicians, and that does put just more burden. And it also does cause physicians sometimes to just stay at places where they're not happy with. And I'll admit that is something I think that a lot of physicians really are worried about. Well, how would I be perceived by the community, or how would I be perceived by some people? And the only advice I can give to them is don't worry about others, because you can't make everyone happy. Just focus on ourselves, on yourself. And that's always good, not just for physicians, that's good for anyone, whether that is people in administration or people in nursing. If you cannot take care of yourself, you're not going to be able to take care of others at the end.
Well, I'm glad you brought up AI because everyone wants to talk about AI replacing physicians, but that's the wrong conversation. Why shouldn't we be talking about a system that's been built that requires physicians to spend so much time doing other work that AI could eliminate?
I am of the school of thought that AI can be an adjunctive asset to physicians. And that can be in terms of, like you said, documentation, in terms of reaching out to the patients, in terms of making their lives easier. The issue becomes, I think, is a concern for mistrust. And the reason I say that is about a decade ago, we started hearing about radiology being replaced by technology, right? And we're still here. And now the problem is we don't have enough radiologists. That's the issue, because we've driven medical students out because everyone's worried about them getting replaced by AI, and we're not there, and we'll never be there. And the reason for it is because the human element is always needed within healthcare. There's something different about a robot sitting and telling someone you have high blood pressure compared to a living human individual who knows you better and who has actually done nothing in their adult lives but learn and educate themselves regarding medicine, right? That human element will never really be taken away. I know that there's some concern. I know the state of Utah has been doing an AI prescribing service, which there's been an uproar about, and I do agree that is concerning, but not necessarily for the fact that it's being done, but rather for what is the next step going to be. And when you don't know that, when you don't really have any particular guidance about what the next direction is, that's when people get nervous. And I wish when that was being done, and maybe there's things I and you don't necessarily know about the whole intent of that prescribing service. But when you're doing these kind of things, I think there's always a good it's always a good idea to come up with, okay, this is what the goal of doing this is, And I don't necessarily think that was stated well. And I think that's where the concern's coming from.
So you've written about obesity and preventative care, primary care, health policy. So why does healthcare continue to spend so much money treating diseases versus preventing them?
I really have no idea. And this is one of the reasons why I'm also a huge advocate of GLP-1s because they work, right? I'm on one myself, but also 2024 was the first year in forever when we actually reversed the obesity trend on a national level. Yes, it was only by like 3%, but that is still a big change. That is still a good sign. So I've never really understood that. I still think it goes back to that word called greed because do you really want, if healthcare is a business, do you really want everyone to be healthy? That's where I'm really, I really kind of feel that comes from. I'm a huge advocate of trying to get more and more insurance companies to cover for GLP-1s. And we know that obesity is linked to so many different chronic illnesses, whether it's hypertension, dyslipidemia, type 2 diabetes, even to some degree depression, anxiety, cardiac issues. But we don't necessarily, I guess, as a system, still see it that way. But I'm hoping we're going to here in the next couple of years, as we continue to see the benefits of GLP-1s. And I always say this: we're at the cusp of a revolution when it comes to obesity medicine. We only right now have about a few options, but over the next decade, you're going to see more and more newer options become available, and some of them are much better at not only treating obesity, but perhaps even preventing it from an adolescent age. And that's going to be a significant revolution. But let's wait. We'll just have to give it some time and wait and see how we can figure this out down the road.
It seems like a lot of my episodes lately, the word greed has come up quite a bit. And I think you're right. I mean, because you look at pharma doesn't want diseases cured. I mean, my gosh, because if someone's cured, they no longer need your product. So why would they go whole hog on that? So we talked a little bit about AI and data. So what concerns you the most, that the technology won't work, or that the healthcare leaders will implement it without really changing how they lead?
I think it's the second part. I think one of the problems with the current U.S. healthcare system is, the reason why we spend $15,000 per individual and still have poor health outcomes compared to other developed countries is 30% of all those costs are going to admin, right? And we need to shrink that because there's really no other way we could really make this work financially. But I also think we have seen, and we can give great examples, like you and I definitely can. And I'm not going to say any names or anything here, but I think part of the reason why hospital systems are struggling is a lack of oversight necessarily on administrative decisions and a lack of communication and a lack of understanding between clinicians and administrators on how to solve the issue together. I think what happens is admin gets very ambitious, and that's rightfully so. And then at the end, what happens is a lot of those end up being poor financial decisions. And whether if that is expanding or building a new building or hiring more staff too aggressively, too quickly, and then having to not really understand the intricacies of how to make that work financially, and then regretting it, and then having to cut back on more significant productivity or more significant staff. And that's a shared story, which I'm pretty sure all of our listeners can relate to, whether that is in Oklahoma, Arkansas, California, Texas, or heck, even North Dakota, right? So that is the problem. And I think that it's that mistrust that clinicians have within administration that I feel is what's really causing that panic or that fear. And even the Department of the Health Education, sorry, the Health and Human Services Secretary, he was initially advocating for AI replacing primary care because it's going to be done at a much cheaper rate. If that was the case, I'm always up for it. But at the end of the day, that is not going to be the case because primary care isn't just about giving you a medicine for blood pressure, right? Or just here's this pill. We'll see you in 6 weeks. It doesn't work that way. I wish it did. That'd make my life a lot easier. But that's not the way primary care works, right? So, because there's a lot of things that the human element can catch before a computer algorithm can.
Oh, absolutely. Well, we've talked a little bit about how physicians are really feel like they've lost control of the profession they entered. Uh, you know, how how do you think we can give physicians their voice back without returning to the way healthcare operated, say, 30 years ago?
So I've thought about this, and I kind of look at, I'm also a big NBA fan, right? And so, most of the sports leagues now have their own players leagues and players unions, and that's kind of what I feel like is going to be necessary. And I don't mean that in a negative way. It's not that we're trying to put the blame on one side. It's not that we're trying to put the blame on just insurance companies or admin or big pharma. But I think if you're able to unionize physicians together and give them a voice, I think that could actually help bring them to the table, but also it'll give physicians an ability to have a bigger voice, right? Part of the reason why I've even decided to go into physician leadership, into executive, the C-suite idea, is to be able to help make better decisions, but also help make decisions that you're not necessarily compromising quality of care for the financial sake, right? And so I think unionizing physicians is an idea that I support, and I think it might actually do good for everybody. It might do good for the administration side because they will now have people that they can talk to, right? A set of leaders, but also an organization that they know will be united, and so they don't necessarily need to spend the time and the energy invested in talking to different groups of physicians, right? But also it gives physicians an opportunity to give them a voice, to be able to have a group set of leaders that are able to discuss with administration what the concerns are. The problem I think that the physician community has done is it's tribalized itself into specialist versus non-specialist, inpatient versus outpatient. And when you do that, you end up basically giving away whatever negotiating power that you have because each of you has different vested interests, right? And if you can get rid of that idea, the tribalism, I think you could do much better as a community, but also I think you could do much better advocating for yourself as a community. And we don't have that right now. Now, I know people might get a little bit upset. Oh, what? No, we don't need a union for physicians. And even some physicians may disagree with me. But if you look at it just from an objective point of view, what is the biggest issue right now within the physician community is if you feel like you're losing your rights compared to in comparison to other APPs, if you feel like you're not getting paid well, and if you feel like you're not really getting a seat at the table, well, maybe you do need to unite. And the way you can do that is the union.
Hmm. Boy, that's a bold direction. From my perspective, I've seen a lot of hospitals over the last few years, um, and bring in physicians in the CEO president position to really, I don't want to say combat the union, but yeah, kind of that way. But I think another issue too, because I started my healthcare career on the business development side, so I talked to a lot of physicians early on and got to be friends with them and got to know how many of them thought. But and so I carried that into my administrative career. But and I told the last hospital that I joined early on, whenever I was speaking with physicians as the chief operating officer, I said, guys, look, I said, I'm always going to be honest with you. I said, there's going to be times that you don't like what I tell you, but it's going to be, it's going to be the way I see things are, and I'm always willing to talk about it. And so, that really helped me in my career being a non-clinician, to be fairly successful. But one of the things too, that you have to bring into play, and come on, you're gonna admit this with me. There's some pretty sizable egos in the physician world, right? And so, it's not only between the primary care and specialists, it's between neurosurgery and orthopedics, or general surgery. Hey, who's going to get the biggest toy? And then they start turning on each other. And so, there's got to be some way. And again, in many of my more recent episodes, we're talking about healthcare's got to return to that patient focus again. We've got to be focused on what's best for the patient. And so, how do we get back to that and get everybody, singing from the same songbook on, like, what we're doing here is best for the patient.
Many years ago, when I was a grad student at the College of Public Health here in Oklahoma, I had a chance to do an internship with this organization called Health Alliance for the Uninsured, which was an umbrella of the charity clinics within the Oklahoma City metropolitan area. But during that course, I got the chance to meet a gentleman by the name of Stanley Hepburn, who was the former CEO of Integris Health. Yeah, and he said something to me that I'll never forget, and I'll take this with me to my grave, literally, at this point, because. And he said, some of the best people that I ever met were doctors, and so were some of the worst. So when you bring up the word ego, right, I'll be the first one to admit, yes, absolutely, I do agree. And I hate I hate saying this live, but part of my motivation getting into medicine was to help bring that aspect down within the physician community. We are not here to put someone down. We're not here to, make ourselves feel better as if we're some higher level of the human species. We're here to serve patients. We're here to serve the communities, right? That is part of my motivation of getting into medicine, was to show this is what a physician should be. And I completely agree with you. Yes, we do need to make it patient focused. Yes, we do need to return back to that idea. But I think the issue is if we want to do that, you're going to also have to balance that out, and not to do that at the expense of clinicians, whether if those are nurses, phlebotomists, physicians, anyone within the healthcare community. And I think the issue is there also has to be some degree of individual accountability. And the way and what I'm referring to is, one of my favorite authors of all times is Michael Crichton. And for our listeners who don't know who that is, that's the gentleman that actually wrote Jurassic Park, The Lost World, The Andromeda Strain. But what a lot of people don't know about him is he actually went to medical school at Harvard, and he was actually he's a physician, and he never pursued residency training. And when asked why he never really pursued residency training, why didn't he continue his career as a physician? And his words, and I'm paraphrasing this, but his words were, it didn't make any sense to me why I should be trying to take care of issues that really have started 30, 40 years ago with people not taking care of themselves, right? And whether if you agree with that or disagree with that, that's a whole different story. But I think it brings something else to the forefront, and that is individual accountability. And we also have to keep ourselves as physicians accountable, ourselves as administrators accountable, but also as patients, we also have to keep ourselves accountable. So we need to go back to the idea of what you said, prevention, but we also have to encourage healthier lifestyles, right? I did my residency training in White River Health System in Batesville, Arkansas. Beautiful, beautiful town in north central Arkansas. If you guys haven't been, it's a really beautiful town, especially during the fall season with all the trees that you see. But one of the things that I've always stated very well was, what are they feeding you in the hospital? Well, I'm getting pork and French fries and a diet Coke. Well, a 32-ounce diet Coke really doesn't make a difference, either whether it's diet or regular, really, right? So again, we have to go back to the idea of prevention, of individual accountability. And I agree, patient focus, but I think everyone has to play their role. And what I mean by that is putting aside your egos, working towards a common goal. And that goal is to try to help patients get better, but also try to promote healthier lifestyles and try to bring down healthcare costs. Whether if you, no matter what side of the aisle you were on the political aisle, the Affordable Care Act, despite it not being great, despite it being flawed, I think you have to appreciate the fact that at least it was trying to compromise all the different political, issues, and here and we are. But the one thing it wasn't really doing well is bringing down healthcare costs. And ultimately, that's what basically killed it, right? And so we need to find a way to do that. Now, am I going to have the answer to it? Probably not. I have my own opinions. I was thinking of maybe a single payer system, but I say that word and everybody else is going to, start saying other words, and socialism and communism and all that. And I get that part. But earlier today, I talked about the railroad industry and how what went from, a huge, aspect of the private economy in the early 1900s to now becoming a quasi-government structure known as Amtrak. I think healthcare is headed that way, and I think you're going to have to do that at some point down the road, because there's really no other way you could control the rate and the cost doing it through the private world, because we've been trying it. We've tried it for 80, 90 years, and here we are, right?
Those are some strong words, and I think that's a good point to end on today. Hey, any final words though? I'll give you a couple of words to end on.
I love my job. Being a physician is something that I thoroughly enjoy doing. It is challenging. And to all of those that are listening that want to go into medicine, it's a great profession, but you have to persevere. And whatever challenges that you face, whatever obstacles, whether that be personal issues or setbacks or failures, don't ever look back. There's only one direction, and that's moving forward. And at the end of the day, this is a very complex question that we're all trying to answer: is how do we fix healthcare? But we can't do it individually. We can only do it together. So we need to put aside our political differences or social differences and come together, and we can fix it. We've done this before. As a nation, we have faced so many obstacles, and I'm confident we can fix this issue too. But we're going to have to come together, and we're going to have to come together with an open mind, and we're going to have to come together understanding we're all not going to get what we want. We're going to have to compromise, whether that is our ego or whether that is money. We're all going to have to set all that aside and come together.
Very good. Okay, those are better words to end on. I like that. Dr. Krishna Vedala, thanks for joining me on today's episode of I Don't Care with me, Dr. Kevin Stevenson. And thank you, audience, for joining us. Hope you enjoyed today's discussion as much as I did. If you did, come back, see me next week for another episode of I Don't Care. Take care. Bye.